I'll little bit extension of this, because right now what we're talking of local advanced gastric cancer vis-a-vis early gastric cancer, we all know that T is what we can evaluate preoperatively. N is what we cannot evaluate confirmatively, preoperatively, or even postoperatively. Only a surgical specimen will tell us. So when we're talking of complete pathological response, I understand we're only talking of a T complete response.
No, you've done surgery and there's no.
So now we are looking at early gastric cancer, T1 or T2. So we should not differentiate between early and local advanced when we talk of complete pathological response, because if that can work for T1, T2, that can as well work for T2, T3, T4. Now what we have seen in the resected specimens is the amount of lymph node positivity beyond T2 is much higher. So if we have a T response to a neoadjuvant therapy or whatever T stage, if the T disappears, how sure are we that the N has disappeared? So that is where I think should still, until we identify a role where we can identify the N0, N1 without surgery, do we rule out a surgical option in all these patients?
So I think when you say pathological complete response, there are two things that go without any further description. One is your patient has had some neoadjuvant therapy. Two, your patient has had a proper gastrectomy with D1, D2, D3, D4, whatever it is. There's nothing like a pathological complete response in the absence of surgery. So there is nothing like evaluating your lymph nodes pre-surgery and then saying that my patient has got pathological complete response. We still haven't perfected the art of finding out whether post-surgery your lymph nodes are positive or negative. You can only reach that far with all your EUS techniques. You can't go beyond that. So it's nearly impossible to say. So that is where, for lack of time, I didn't expand. We are looking at ctDNA. We are looking at better imaging, right? So which will be better for lymph nodes. Unfortunately, the positive and negative predictive value of a PET CT scan is not optimal enough for us to say if the PET CT is negative, there's no disease. Or if the PET CT is positive, there's definitely disease, right? We routinely do PET CTs in our center, right? Let's not get into whether that is necessary or not. I think all of us do that. There are instances when I've sent somebody with a CT2 N0 based on a PET CT for surgery. Our surgeons will pull out some 100 lymph nodes after their endosign in green, and you will find that 25 of that are positive. This patient had nothing on the PET CT as far as lymph nodes were concerned. So we haven't perfected the art of saying without surgery that the lymph node does not have disease. So if you're saying PCR, it means you've had neoadjuvant therapy and you had surgery. In the future, maybe that definition will change. You may be able to estimate all of this better without surgery. But as of today, you guys will determine what PCR is, not me. I may see that and then say it's good, it's bad, it's ugly, but you still hold everything.
Yeah, this is understood after by imaging, whatever we say, complete response, it is not a complete response in every case. In esophagus, take it about 20% there is a lesion, but it will cannot be detected. Same thing stomach as well. So that's why once we complete neoadjuvant therapy, you have to proceed with the surgery. Subsequently, nodal clearance. So every node's negative, it is good enough. Suppose a positive, subsequent decision we can take based on the biopsy of the nodes. That's why there is no present day, one can say after that, complete response. Not detected, there is a different, but we cannot say completely cure. If you tell the patient that you are completely cancer gone, then the patient will not likely to go surgery. So that is why we have to be a little careful using the word to the patient, what to do, how to proceed subsequently. That is, after surgery, we have seen many patients coming, nodes completely negative, but stomach wall carrying the lesion. At the same time, stomach sometimes very residual, but nodes, multiple nodes. What we thought, PET scan sometimes inflammatory nodes, this side, that very difficult to predict. But there must be adequate gap you have to give, again investigate, proceed for your prognosis point of view, that is only.
And just to extend on what Dr. Pratap Reddy was asking about MSI high tumors, MSI high tumors typically have large burden of lymph nodes. But all of those lymph nodes will be negative if you dissect them. All of them will light up on the PET scan. Okay, so the physiology is totally different there. The biology is totally different there. So as sir was rightly saying, if you don't find a tumor, great, we are very happy. But when you operate, you will still find 20-30% showing pathological positivity. And the vice versa also can happen. You can still see some residue on an endoscopy when you do post-neoadjuvant evaluation. You may still see some lymph nodes on the scan that you did, but when they operate and then you see the pathology, you will see that there's no disease there. So both can happen. So that's why I said, and as rightly sir has said, we haven't perfected the art of saying based just on imaging or a little bit of pathology here and there that somebody's tumor is completely cleared versus not. We've still got a long way there. So unless you get rid of the tumor, we just don't know what was there and what is there.
I think when I hear last question, I wanted to say, get a suggestion from them. If a peritoneal mets, small bowel or omentum, and the stomach also T4, and this is only systemic chemotherapy or HIPEC combined. What is your opinion? We have done a limited series patients and a couple of laparoscopy done. Once in the secondary, all peritoneal become negative, then proceeded with the gastrectomy. And some cases results good, some cases again comes back with the recurrence. Suppose there is a peritoneal positive ascitic fluid, otherwise no meds. There you go for HIPEC, only systemic. Any suggestion anybody happy about? Because nothing is proved. Exactly. It is only by everybody's experience. I am given answer. Majority, like voting in India, if everybody says, majority will confidently say that.
I think you answered the question right, because there isn't a randomized study which has shown that HIPEC in stomach cancer really is beneficial in terms of improving overall survival. I think it will come sometime. So the problem again is that we are not good enough to assess the biology of the disease. If you're able to assess the biology and say, okay, here is a guy who's got this molecular abnormality, this stage, limited peritoneal disease, so if I go aggressive on this patient, I'm likely to potentially cure, at least improve overall survival, then we can make that choice with a lot of information. But at this point in time, it's a lot of judgment that goes into doing surgery and HIPEC rather than a lot of objective data that goes in. So I don't have an answer at this point in time, but if you look at the literature, it says that there is no evidence to do it. So, but including our own center, on and off, we kind of do extensive resections plus minus HIPEC and so on and so forth.